The American College of Cardiology and MedAxiom are transforming cardiovascular care together. Welcome to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom Heart Talk starts now.
Hi, it's Pat White, President of MedAxiom, and I'm here today with a couple of members of our group that are going to talk about unwarranted variation. First of all, Dr. Peter Duffy, who is a member of FirstHealth of the Carolinas. He's the treasurer of SCI, and he's also a member of the Interventional Council for the American College of Cardiology. So welcome, Peter. And also Dr. Thomas Schleeter. Tom is the chairman of the St. Vincent Medical Group Cardiology Division and has been a member for many years. And welcome, Dr. Schleeter.
Thanks, Pat.
This has got to be a hot topic. And I was thinking the other day that Amazon, JP Morgan, and Berkshire Hathaway has hired Atul Gawande to be their CEO. And given his history, I've got to believe that unwarranted variation is going to be on his agenda. And wondered if you could reflect a little bit about some of your thoughts about how we're going to attack this issue. Peter, would you like to start?
Yes, I think what you brought is a very compelling issue there that we really do have to face, and that's unnecessary clinical variation in care. And I think one of the issues we've got to face is that systems are not really incentivized or set up for structured care, which is really what addresses unnecessary variation. And various reasons for that. I think that one of the major problems is that there's an investment of time, people, and money to be able to do that, and hospitals and systems are not always clear on what the return on the investment would be where they just start to do that. So once they start it and they've got people committed to it, then they've got to look at what data is it that they want to really get, how do they want to use that data, how do they want to implement changes in their system, how do they reflect those changes and ascertain whether those changes are what they want them to be, and how do they reproduce that on a regular cyclical basis. And that's a real commitment of resources and administrative talent that many systems don't have right now, the resources to be able to do or the ability to do even if they wanted to do it. So let's say they wanted to do it. One thing would be, what do you pick? What processes do you pick? What procedures do you pick? What's the low-lying fruit? And that may be different for different institutions, and it may be hard for them to even ascertain what it is for their own institution. But if they've gotten that far and they did pick something, then it's also difficult sometimes to set up what that structure would be, how you would go about doing it. Because there's what we want, of course, is the best practices. Where do we get the best practices right now? Well, in many ways in cardiology, that's from use of appropriate use criteria and using guidelines. But guidelines really are derived from major clinical studies, which are usually double-blind, randomized controlled trials, which exclude a lot of patients that would be typical of the patients that we would be seeing in a general practice. So there's a lot of hesitancy to say that that's applicable really across the board. Registries are very useful, but they provide more outcomes data and don't really tell us how we did something. And then I think also there's physician and practitioner buy-in that has to be an important part of that equation as well. And while we see many systems hiring physicians, they don't necessarily integrate physicians into the daily practice in the system itself. They're employing the physicians, but they don't have them having a vested interest in what's going on in the system there. And if you look at hospitals that have a lot of hospitalists, there may be turnover in the hospitalists, so that would be an issue. Bringing new people in, educating them as to how you want that process to go may be difficult. Then I think there's some cultural issues involved as well. And that means, what was your training background? How did you do something? And are you going to be really willing to change how you take care of a patient when, for example, that may not be how you were trained to take care of the patient, or your own experience tells you that you were doing something differently and getting what you thought was a good result, so you want to continue doing it that way. And I don't think the systems are set up then to incentivize practitioners to be able to do that either. So I think those really, to me, summarize why we have unexplained clinical variation, because we really don't have the incentive for systems to change that right now, as we still stick with more volume-based care than value-based care.
What's the statistic? It takes 17 years for something from the beginning of clinical trials until it's fully implemented in medicine. It takes 17 years. So I guess wiping out unwarranted variation is not going to happen overnight. Tom, once you've identified outliers, how do you approach an outlier to affect change?
That's a great question, and I think it really has to be taken from a physician level to a physician. And the idea isn't we're trying to stifle your creativity. Peter just alluded to. we're utilizing guidelines or evidence-based guidelines that have been developed. And if you're not adhering to those, that's where we see that variation. That's what we want to eliminate. We certainly want to be careful with the way we talk to physicians about this. We certainly want to not stifle their creativity, but certainly allow them to practice the way they wish to practice, but certainly follow the right evidence, follow the right guidelines, and when there is a discrepancy, try and find out why that is, because honestly, most of the time, people are using good thought and trying to do the right thing for patients. I think we still don't understand what it means to remove variability in practice. I still think we're struggling with that idea. So as time goes on, I think we'll be able to explain this much better. But it has to be physician-to-physician communication to make this work.
No doubt, physician-to-physician is important. What about employed versus private physicians? If you have both within the hospital system, how do you deal with bringing people that are in independent groups that might not find the need to toe the line, so to speak?
Yeah, so I think what we're seeing is the development of the professional services agreement of the PSAs under that circumstance. And so what the hospitals and systems have to do is find a way to make it attractive for those physicians to be able to buy into and join that physician services agreement. But again, it's equally as important that once you get those physicians joined into that you create the culture that they feel comfortable with and they feel that this is the right thing to do. So it's not just a matter of signing a piece of paper, it's really integrating them into the success of the system and creating those values that you want to have them meet and metrics you want them to meet. And that sometimes is very difficult because administrators may sometimes think, well, once we've got somebody signed to a contract, that's it, they're part of the system, that's all we really have to do. But there what you really have is simply an employed physician. You don't have a physician integrated into the success of your system or your practice.
Yeah, changing patients' health behavior is not easy, and changing physicians' behavior is not easy, I'm sure. What about from a technology perspective, electronic health record? Are there technologies that can help in change behavior?
From what I've seen, certainly. I think, and that's the wave of the future, is certainly have an electronic medical record or health record that can really assist with this, that can really identify from drugs to procedures to just anything related to patient care, prompting you, saying, listen, this is different than what's usually done in the standard care of taking care of this patient. Not that you have to change that, but at least you have the rationale saying why I'm doing something different. We still struggle with this. Our electronic medical records aren't as robust as they should be, and while we are trying to eliminate variation, it is a struggle when you don't have an EHR that can assist you with that.
Great. Well, thanks so much for being here. We look forward to your presentation later today with a very, very compelling argument that needs to be made.
Thank you very much, Pat. Appreciate it.
You've been listening to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together to transform cardiovascular care for all. You can follow MedAxiom, an ACC company, on LinkedIn, Twitter, Facebook, and YouTube. If you haven't yet, please subscribe, rate, and review this podcast. Join us next week for another MedAxiom Heart Talk episode, and thanks for listening.